Welcome everyone and good afternoon. My name is Allison Jones. I'm Director of Program Strategy and Management here at the Alliance for Health Policy. We are a nonpartisan, nonprofit organization dedicated to helping policymakers and the public better understand health policy, the root of the nation's healthcare issues, and trade-offs posed by various proposals for change. We're thrilled today to presenting our webinar, Perspectives for Media on Value-Based Care in 2024. The Alliance has served as a trusted educational resource for the health policy community for more than 30 years, and today's webinar will explore the current value-based care landscape, highlight anticipated policy discussions for the coming year, and identify key considerations for reporter and other media experts. We are excited to showcase a range of healthcare and policy stakeholder perspectives on value-based care as part of today's event, and hope this discussion will help you all in your work to advance solutions for improving our healthcare system. Before we get started, I want to take a moment to thank our event sponsor. Today's webinar is made possible with support by the National Institute for Healthcare Management. We are grateful for your support of this program and for all you do to improve healthcare by advancing diverse perspectives on health. I also want to share a few quick logistical notes. As always, we invite you to follow the Alliance for Health Policy on LinkedIn to stay informed about upcoming events like this one. You can also find us on Facebook and YouTube. Today's panel will have a Q&A section at the end, and we encourage you all to be active participants. So please feel free to share your questions throughout the event. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit any questions you have for the panelists at any time. We'll collect these and address them during that Q&A. Throughout the webinar, you can also chat us about any technical issues you may be experiencing, and our team will assist you. If we don't get to your question, please don't hesitate to reach out to us at info@allhealthpolicy.org, and we'll do our best to connect you with additional information. With that, I am so pleased to introduce our moderator for today's webinar, Susan Dentzer. Susan Dentzer is President and Chief Executive Officer of America's Physician Groups, a nonprofit organization representing more than 360 physician groups focused on patient-centered, coordinated, and integrated healthcare that is accountable for both cost and quality. Susan is a highly respected health policy thought leader, a frequent speaker, and an author of commentaries in the New England Journal of Medicine Catalyst, the American Journal of Public Health, and others to name a few. You can read more about Susan's background and the bios of the other panelists on the Alliance website. And with that, I'll turn it over to Susan.
Thank you so much, Allison, and hello to all of you joining us for this webinar today. It's a real pleasure to be moderating this discussion on value-based care in general, of course, and then the outlook for value-based care in 2024 and beyond. I'm delighted, particularly because our organization is singularly committed to advancing the cause of value-based care. All of our medical groups, all of our roughly 200,000 physicians are engaged directly in various value-based care models. So this is a subject very close to our hearts, as it is, I know, to all of the hearts of our panelists today. And they are indeed a very distinguished bunch. So I would like to begin by having them all briefly introduce themselves to you joining the webinar today. Let me start with one of our very distinguished speakers, Purva Rao. Purva, would you introduce yourself to the group?
Happy to. Thanks for having me here today, Susan. My name is Purva Rao. I'm the Chief Strategy Officer at the CMS Innovation Center. Really excited to be on this panel with everyone today.
Great, and thank you, Purva, so much for being with us. Sarah Levin, please introduce yourself as well.
Hi, good afternoon, everyone. I'm Sarah Levin. I work on the Ways and Means Committee. I am the Deputy Staff Director for the Health Sub. Look forward to this conversation today.
Great, and thanks, Sarah, so much for joining us. And David Pittman.
Hi, my audio issues are just back in time. David Pittman, my title is Director of Regulatory Affairs and Communications for the National Association of NICOs. NICOs represents about 430 ACOs nationwide, covering about 9 million people. I specifically work on regulatory affairs, mostly for us, but I also have a background in journalism. For the first 10 or 12 years of my career, I worked as a journalist, working for local newspapers and trade organizations and trade newsletters in DC, but my last job was working at Politico, where I helped stand up their health IT coverage and cover providers before leaving and I've been at NICOs for about 6 years now.
Great. So David comes to this topic with multiple perspectives, current and past. Thank you, David, for joining us. And finally, we're really happy to have with us also Anshu Chowdhury. Anshu, would you introduce yourself?
Yeah, thanks, Susan, and thanks everyone for joining us today. My name is Anshu Chowdhury. I'm the Vice President of Policy Development and Strategy at the Blue Cross Blue Shield Association, which is the trade association, which represents the 33 Blue Cross Blue Shield companies around the country. I've been with the association it'll be 19 years in May, and been close to value-based care over the year, and excited to get to have the opportunity to spend some time with you today.
Great. Well, thank you, Anshu. And as you can see, we've got a great series of perspectives to bring to bear on this question of whether value-based care. To start us off today, I'd like to do some grounding discussions of what we mean when we're talking about value-based care. All of us have probably the unfortunate task sometimes of explaining to other people what we do and why we do it. They have usually no idea what we're talking about. And what we have certainly found is when you say the word value to regular old human beings, they kind of think you're talking about something that's at the corner maybe of Kmart and Dollar General, a value proposition in healthcare, right? And we know that that's not what the attempt is behind value-based care. So clearing up a lot of these misperceptions, frankly, and it's not just consumers and regular people, it's sometimes policymakers, as we know, is really, really important. So to get to that level, let me ask all of us to fantasize for a moment that I am some kind of weird alien creature, Martian or whatever. I've landed on planet Earth with the instructions of trying to take back to my folks back home some understanding of what the heck we're talking about when we say value-based care. So I land here, I have almost no understanding of the US healthcare system as it is. I don't even know if it's really a system, frankly, but I wanted to understand what this whole concept is all about. So I've been handed a list of instructions from my bosses back on Mars or wherever, and they tell me the first door I'm supposed to knock on is somebody at some place called the Innovation Center at the Centers for Medicare and Medicaid Services, which leads me to knock on the door of PERVA. So PERVA, I'm an alien. Tell me how you explain value-based care.
Well, first, I'll just start by saying, Susan, that might have been the best opening question that I've ever gotten. And I just want to thank you for moderating today's panel, because sometimes these topics don't make us laugh enough. And thank you for shaking it up. And thank you to the Alliance for Health Policy in particular for hosting today's event. I think this is a great addition to Value Week. And I hope that many of you that are online today have joined and hopefully are going to join the many discussions that have been continuing and taking place over the course of this week. I think you asked a great question and a really foundational one. Value-based care is a term that we use to describe healthcare that is designed to focus on the quality of care an individual receives, their care experience, and provider performance. When we talk about value-based care at the Innovation Center, and we test new models that try to innovate in terms of payment and care delivery, we emphasize integrated and coordinated care, meaning healthcare providers work together to address a person's physical, mental, behavioral, and social needs, so whole person care. So in this way, providers are treating an individual as a whole person rather than focusing on just a specific health issue or disease. Currently our fee-for-service payment systems aren't designed to meet the needs of patients in that holistic way. And oftentimes the financial incentives in the fee-for-service system, and Susan, maybe many of your members, have indicated this to you as well, it's not always optimal for physicians and other healthcare providers who want to provide that type of person-centered or whole person care and focus on those patients that need more time. And we know that the fee-for-service system ties financial incentives to the volume of care delivered. Sometimes it can drive unnecessary procedures or duplicative tests, care that sometimes can be more expensive for people and to the system, and honestly contribute to fragmentation for patients and families. And there's some recent data, I think, that really underscore the complexity that people are facing as they're trying to navigate the health system. For instance, nearly 30% of Medicare beneficiaries have 2 to 3 chronic conditions, 22% have 4 to 5, and 18% have 6 or more. You think about the daily complex conditions that our beneficiaries are living with, and then the proportion of beneficiaries that are seeing 5 or more physicians annually has increased from 18 to 30% from 2000 to 2019. So not only are people dealing with more complexity in terms of the health challenge that they face, but they're also trying to navigate multiple different providers across different settings. So more than ever, I think we need new ways of paying and delivering care. Well, what should value-based care look like for a patient, and what does that word actually translate to for an individual? So I'll just share a quick example of how at the Innovation Center we try to use value-based payment to support that more person-centered care. So we have a vignette of a patient, a beneficiary in one of our kidney care models, and she was being served by one of the providers in a kidney care model, and she found out that she needed to start dialysis, and she actually used the words that she found it was crushing, because she reported thinking of her own mother, who would wake up at 3 a.m. 3 times a week to receive dialysis, and that's what she thought she was going to have to do. But because this provider was in a value-based payment model, she was actually able to work with that kidney care provider to receive home dialysis. Luckily, she has support at home from her husband, which allows her to receive dialysis at home more easily. She can do this multiple times a week while eating dinner, watching TV, spending time with her family, or her friends visit. And amazingly, she was also able to continue working as a director of child care services at a social service agency before she retired. So it's not the payment that is driving what happens in value-based care, but it should be the quality outcomes and experience. And you asked about the Innovation Center and the role that we play. We test new approaches to care delivery and payment. And the common goals of these models are to improve patient care, ensure that people have access to high quality care, and to reward healthcare providers for delivering that high quality and cost efficient care. So you can think of the Innovation Center as the R&D component of CMS. And our vision is really to build a health system that achieves equitable outcomes through high quality and person-centered care, and use a combination of incentives and standards to try to accomplish those goals. So our models and our tests can include things like upfront investments for infrastructure and data that give providers the ability to identify, for instance, the sickest patients, like who's most likely to be hospitalized or readmitted, and how can we get ahead of that and help. Our models can include regulatory flexibilities that let providers care for patients in lower cost or more convenient settings, such as the home or in the community, and provide more services through non-physicians. Our models include electronic tools and data. We know that data is really important for providers to coordinate care, for instance, between primary and specialty care providers. And then, of course, our models include payment innovations that give providers more stable and predictable payment and incentives that reward better outcomes, higher quality, and a better patient experience. So I'll stop there, but I'll just give a little plug for those of you that want to learn more. The CMS Innovation Center recently launched a new value-based care spotlight with patient and provider stories and a lot of other helpful information. So I'll just put in a plug to visit that site if you're interested in more of our work.
Great. Well, thank you, Purva. So as an alien, my head is spinning as I try to absorb all of this. But what I'm taking away from this is that although Earthlings probably go to the doctor thinking that they should always get quality health care and that it should be focused on them as people, that doesn't always happen. And part of the reason it doesn't happen is because of the way we pay these healthcare providers. So we need to figure out ways to pay them differently so they're incentivized to do these things like provide quality and be really focused on patients. And I guess what I'm also picking up is that you're involved in something that does this through the Medicare program, but the briefing documents I read showed that there's a lot of money floating around the system that is not Medicare or Medicaid. It's private payments. So I'm trying to understand how this movement relates elsewhere. So that means I'm going to go knock on another door, which is that of Anshu. And I hear, Anshu, you have something to do with other money that's not government money. So explain to me value-based care in that context.
Absolutely. Thank you, Susan, and thank you, Purva, for kind of setting the stage on how this works on the government side of things. And, you know, we, Blue Cross Blue Shield companies, collectively, our plans serve 1 in 3 Americans. And so we do have a very large role in the healthcare system, working closely with the government, and then also working closely with employers as well, who look to Blue Cross Blue Shield for insurance. And you know, we collectively serve, as I mentioned, the 1 in 3 Americans. And what we try to do in our models, to the extent that we can, is find alignment with, in some cases, with what the government may be doing. And in the types of models that Purva laid out, But if there's not going to be perfect alignment, there's going to be a very similar framework for how we structure value-based care programs. And so it's the same sort of core principles around improving quality over quantity of services provided, making sure that there's a focus on prevention and it's a proactive approach to care rather than a reactive approach to care, making sure it's the right care in the right setting. And ideally there's a primary care foundation in the value-based care model, or at the very least, if it's not a foundation, because it might be focused on a particular specialty care model, then at least there's a connection and there's a team of providers that are working together to provide comprehensive care, coordinated care across settings and stages of life. And so as a health plan, one of the things that we do, in addition to paying and then maybe looking at different ways to pay differently for this type of care, we also are able to provide resources to practices that we partner with or to hospitals that we partner with. And so we have a lot of data at our fingertips as a health plan. And so part of what our role is, where we can help practices and hospitals, is providing data so they can see the entire sort of picture of a patient's care. So when a patient enters the four walls of let's say it's a primary care physician's practice, and they are treated in a patient-centered way in a let's say a medical home type of model, and then they go somewhere else for a particular service, or maybe several months later they go to another location. We're able to provide that data back to the provider who may not see that whole picture, so that patient, their care can be looked at in a holistic way. Also providing information sharing in the form of tools like electronic medical records and other sort of support tools that can help a practice better take care of its entire population. On the payment side of, we've talked a lot about, or I've talked a lot about the structure. The other big part of this is payment, and how do we move away from fee for service? And so there's a variety of different approaches that we'll take in looking at different models, and a lot of it depends first on the readiness of the physician practice or maybe the hospital that we're partnering with, how advanced they might be in these types of models, taking on any sort of risk outside of a fee-for-service arrangement. So fee-for-service, you perform a service, you get paid, but then the risk part of the models, which is kind of where some of the incentives come in these value-based care models, is around taking on some risk for a population where, if you provide care and it leads to better outcomes, better patient satisfaction for either a fixed amount of money for your entire population, or maybe it's bonus payments that are given to a provider that has demonstrated those outcomes, then that's where some of the additional dollars come in. Or in some cases, they might not hit those benchmarks, but that's kind of where the incentives are to continue to drive improvement and continue to make sure that patients are getting the type of care that they need. And so these models take many different flavors in the private sector, but typically they are focused on some of those chronic conditions, and also looking at some of the higher cost conditions where there is the evidence that backs some of the medicine. There's the measures there to make sure that we're measuring the right things and the fair things to measure a provider on, and then obviously there's the patient satisfaction piece, which we always want to build into it too, to make sure the patient gets what they're needing out of the whole experience.
Great. Well, thank you, Anshu. And now as the alien, I'm starting to understand a little bit more about this, but I still have a lot of questions. And one of the questions is, I read that nobody in the US system actually has to do any of this, actually move to new payment models and actually move to really be incentivized around quality and patient-centeredness. So I guess now I'm going to go over to what I understand is a body called Congress that is mainly in charge of passing laws to make things happen. And I'm going to ask Sarah Levin, explain to me what is the role of the legislature in all of this, and why is it that the legislature hasn't made all of this happen? What is the actual role of the Congress in facilitating or making happen value-based care in the government programs, or even all the way over into this private sector activity that we've just heard about?
Yeah, well, thank you, and thank you so much for having me here today. And I, where I'm from Congress, so I have to say something like this, but I speak on behalf of myself and not on behalf of the chair and the ranking member of the committee for whom I work, or the whole committee itself, or every Democrat in Congress. I just speak for myself. But thank you again, and I would say a lot of the messages that Purva and Anshu already described are things that we think about all the time when we're talking about policy. And what Congress does is it makes laws, right? So it sets the rules of the road for all of these discussions, and it has different roles. That's the overall broad view, but different ways it works in Medicare, Medicaid, and in the private sector, right? Because Medicare and Medicaid are governmental programs. There are other governmental health programs as well. And then the private sector, the Congress gives the rules of the road about how the private sector operates, and from a federal sense, obviously states have a role as well. And so what we think about when we're thinking about health policy and what we think about value, I think I would echo what the previous panelists have described, but really we're thinking about this from a patient perspective of, how can we try to create these rules of the road so that a patient can get the right care at the right time, at the right place, and always thinking about, because we're always thinking about budgets and making sure that we're paying appropriately, thinking about how much this all costs, and thinking about what the price is, and making sure that there are fair prices, and to ensure that costs are not overly high. And so a lot of what was discussed by Purva and Anshu are the things that come in as layers underneath that, right? We think about how to make policies to improve affordability, how to make policies to improve access, improve equity, and to make sure all of those kind of drivers are in a patient-centered way. And the way that there are lots of different programs in the federal government that try to incentivize moving towards that direction. A lot of that was, there was a lot of discussion about value in the 2010s, when in the build up to the ACA, and the build up to which created the Center for Medicare and Medicaid Innovation, and a lot of value-based programs, and then including for accountable care organizations, and then also again in MACRA, which was a bill relating to physician payment reform. And a lot of the discussion was trying to move towards a value base, move towards, right care, right price, improve quality, lower costs, that kind of, bending the cost curve. There was a lot of that discussion. And I think that is what is, so that a lot of that, it is kind of entrenched now into the systems, right? We're talking about all the work that CMMI has done to try to bring into what they have learned through their value-based models and try to improve upon that. All the work that Anshu was talking about with, with expanded coverage, there's more people getting healthcare, and how to make sure that you're best serving their needs. And I think the role of Congress is trying to say is particularly now after the focus on the value of 2010s, is trying to think about, okay, what is next? How do we make the next steps forward so that we can improve value and learn from what we've learned in the past decade and move forward?
Okay, thank you. Well, again, I'm starting to gain a greater understanding of all of this, but I still have a lot of questions. And I guess the main thing is, what I'm picking up is that this move to value has been mainly a question of changing incentives for a big system that, as I understand it, costs a lot of money, spends more on healthcare than any other country on this planet on a per person basis. But it's been about changing incentives. Nobody's really been forced to do this, mandated to do this. There hasn't been a national law compelling everybody to move to value-based care. So it's been kind of voluntary. And I guess I'm scratching my head to understand, you've all discussed how this has been going on for quite some time, trying to understand what's been accomplished from all of this, moving in this way of really changing incentives. So I'm gonna go knock on a final door which is that of David Pittman. And I hear tell that he spent a lot of time covering all of this as a journalist. Now he's at an organization that has a major stake in this movement. So David, explain to me what's happened and how pervasive value-based care is, and frankly, what's been accomplished.
Well, thank you, Susan. And I was a little flustered because I had audio issues before. I didn't have a chance to thank the Alliance for Health Policy and NIHCM for hosting this event. Actually, when I was a reporter, I covered a lot of health policy, Alliance for Health Policy panels and sessions in a Dirksen hearing room, and it's kind of surreal to be on the opposite end of this. There's been a lot accomplished, Susan, and I think when people hear the term value-based care or some of these terms, I think maybe they get a little what's the word? They think it's sort of a buzzword and baloney and overused. And value-based care it's a term that is, you see it's overused to the point where it's cliche, but it really does have meaning. And there's been a lot that has been accomplished. Earlier this week, CMS put out numbers that showed participation in their 3 biggest ACO models. It's the highest we've ever seen. It's the highest percentage of fee-for-service patients in Medicare that we've ever seen. Close to 15 million patients. Every year, there's this organization called the Healthcare Payment Learning Action Network that surveys participation and value models across all payers, including commercial, Medicaid, as well as Medicare. And there's a recent report showed that their participation in value models was the highest it's ever been. It's close to 40%. And this is having a real effect. I think that's it's not necessarily translating very clearly in the dollars and cents, and that's because it's just really hard to measure. There's what we call spillover effect, right? Like when health systems, physician practices, they start to add care coordinators, they start to add after hours call lines, so people will call them rather than go to the emergency department. They'll start to improve access in all sorts of ways, but they don't just necessarily do that for certain patients, they do it for all their patients. So when as many people start to get into these payment models and payment arrangements, it begins really hard to quantify what savings are attributed to this CMS program versus that commercial payer. The per capita spending on healthcare in this country has it's still far higher than what it should be. It's flattened out and been pretty much what overall inflation has been the last several years, and that. Again, it's hard to quantify this, but it has a direct effect or direct relationship to what people on this call have been doing, the policy we've been making, the practices we've been making, implementing in actual care, and that's not really appreciated or necessarily picked up because it's really hard to measure. And the CBO, the Congressional Budget Office, has said some of the declines, the flattening out of Medicare spending has been because of care coordination. And this stuff is really the work we're doing, and it's having an impact. And I wish it would translate more concretely to people because it gets hard to measure, and it gets lost in cliche terms and overused jargon, and that gets thrown into press releases because we think it gives you the warm and fuzzy feelings we're trying to elicit. But some of this stuff, for all the reasons that we've talked about, it is really having an impact.
Okay. Okay. Well, as I say, the alien is continuing to ground her understanding of how all of this works. But I guess to stay on your last point, some of my briefing documents picked up on the point you mentioned, David, which is that when people get asked to actually add this up in terms of dollars and cents, some of the conclusions are kind of that the whole effort has been underwhelming. And Purva, I want to come back and knock on your door again, because one of these reports I read was from something called the Congressional Budget Office that basically said in the first 10 years of the Innovation Center, actually more money had been spent on the Innovation Center than had been saved through Medicare changes. Now, is that back to the problem that David just talked about, which is that it's really hard to measure this stuff and it's hard to capture everything that goes on in the system that's not uniquely related to individual payment models? Or help me understand why there's more happening here than sometimes seems to show up in concrete evidence, because that was the gist of what David just said.
Yeah, I'm happy to talk a little bit. You know, the first 10 years of testing and learning at the Innovation Center, I think, has laid a very strong foundation for us to honestly lead the way in the next decade towards broad and equitable system transformation. Each of the models that we've launched, we've had over 50 that we've launched since the beginning of the Innovation Center, they've yielded really important policy and operational insights that really help us address not only those continued challenges with costs and quality, but with also seeing, you know, how we advance equity and patient experience. In the second decade, we're taking those lessons learned and we're focused on using everything we've learned so far to test those kinds of models. And we really believe that we are seeing that change. We're seeing changes in care delivery that improve quality and reduce costs. That helps improve outcomes in the long run. And we're also seeing, David talked about spillover. We're seeing that those changes are spreading to other parts of the system, maybe in ways that we're not quite yet detecting. And to your point, Susan, what are some of those other changes that are happening? You know, we recently published a paper in the New England Journal of Medicine Catalyst on the types of care delivery changes that have taken place in our models, because we want to understand what's actually happening when providers are delivering care through one of these value-based payment models. What's changing for a beneficiary? And we actually found that our model to date are associated with significant care delivery, experimentation, and changes. And so our next step at the Innovation Center is to focus on what isn't and isn't working, and to lean into and to disseminate those changes in care delivery that we know improve quality and outcomes and or reduce costs. And I'll just say, from that retrospective review that we did of our own work, 3 major themes emerged. First, we found that our model participants across a very wide range of different programs used a common set of care coordination and other person-centered strategies to deliver care. So we found that they were actually delivering more team-based care. They emphasized things like patient navigation, again, to help people, you know, navigate that complexity in the system. And they focused on things like care management, using risk assessment and stratification so that you can identify those patients that might be the highest need in your practice. Second, we also found that the types of practice changes enabled by our models allowed providers to actually tailor care better. So we're talking about person-centered care. That is, in essence, what it allowed them to do to meet their own patient needs. I think this is a really important point, again, Susan, probably for your members as well. As providers themselves are experiencing and reporting high levels of stress and burnout, we hope that value-based care models can help unlock that flexibility and innovation for them as well. We found providers in our models were also reporting experiencing that kind of flexibility in how they delivered care. For instance, they were using data sharing as part of our models to support quality improvement efforts. And interestingly, they also supported stronger partnerships with other providers. So even if a provider is not in that value-based payment model, they're actually saying we're communicating more and indifferently around the patient and their care journey. And then the last, theme was around evidence of changes extending beyond Innovation Center models. Again, picking up in that theme of spillover that David talked about. In some cases, we were finding our model tests are time limited, usually about 5 years, some are now longer. We found that models were impacting people beyond those that were served just by the model. So just, not just our Medicare beneficiaries or Medicaid beneficiaries that are in a model, but to others as well in the health system. And that providers, even after a model test ended, were in many cases reporting wanting to maintain those care delivery changes after a model's end. So I think over the last decade, we've had some really significant impacts as part of the value-based care movement on the health system, and we've demonstrated how those payment changes support delivery system transformation and change.
Great, well, thank you. Well, one avenue of value that we haven't discussed so far, and again, the alien picked up on this in briefing documents, is there's another big program called Medicare Advantage, which exists alongside the traditional Medicare program. And most of the models that we've been talking about so far, I've heard you all talking about, have been in the traditional program. So there are variations on the fee-for-service program, whether it's the Medicare Shared Savings Program or other models. But this other avenue, which is Medicare Advantage, I haven't heard you all talk much about. And from what I understand it, that is a very diverse program in itself. It is not monolithic because it is delivered by private plans. But let me go back to Anshu and ask about how at the Blue Cross Blue Shield Association, where you do have a lot of private plans who are participating in that program, how do they see that as part of the value equation?
Yeah, so we, as you noted, Susan, there definitely is, historically there's been probably more of an emphasis on the commercial side, but MA is a significant part of the business, as well as if we are going to make sort of sustainable change over the long run and have these models stick, you have to do it across multiple lines of business and government programs as well. And so plans have been trying to take some of the foundational elements from their commercial business and fold that into the MA model. Although sometimes, because the population needs might be slightly different, it's something that we're still kind of learning or trying to figure out exactly what are the components. We do see that on the MA side for our plans that have been structuring value-based contracts there, what we do try to do to make sure that there is to make it easier on the providers that are also serving patients across multiple lines of business is trying to look for alignment to see like what the provider might already be doing. And so it could be processes that or structural changes or incentives that were tied in on the commercial side that we try to extend those. It could be alignment with like the Medicare Shared Savings Program if they're a participant in that demonstration, looking to see where they have certain capabilities that they might have unique supports needed on the Medicare side relative to commercial, and then also looking to see how we can build in if it is, say maybe it's more focused on a set of physician practices, how can we tie this in with an ACO that might be able to take care of some of the more complex needs that go beyond just primary care? And that's when you can start to see more of the specialty care needs that might be more prevalent among the Medicare population. And particularly if these are smaller practices and smaller independent practices, helping link them with an ACO and form kind of a medical neighborhood, so to speak. So it's not just the medical home, but it's a community of providers that are working together on that. And then on the payment side, it's kind of continuing to try to evolve away from fee for service as much as possible. And whether that's looking at the healthcare, the Learning in Action Network that's been around for a couple years now, and the framework that was created there, but making sure that there are the right incentives in place and trying to align with the different categories. So there's the category 1, which is fee for service with no link to quality or value. And there's the slightly more advanced, which is still based on a fee for service chassis, but there is a link to quality and value. Then there's category 3, which is that's when you start to build in more of the risk. So still built on fee for service, but more risk is being incorporated. And then category 4, moving more towards like a true population-based payment for that group of providers that we're working with. And so we've been trying to create as much alignment as possible with the Learning in Action Network categories and kind of where CMS's priorities are on the Medicare side for MA.
So one way to think about it then, I'm gathering, is so category 4, which you use population-based payment, other people would also say capitation. You think about the model under which, for example, the Kaiser Permanente system plans are organized, that's capitation. You can have capitation through Medicare Advantage. You can have capitation on the commercial side like Kaiser Permanente has, but that notion of the provider entity being entirely at risk for the cost of the care and entirely accountable for both the cost and the quality of care. That's the holy grail that you're describing, that in theory, at least, you all are trying to drive the system to. Is that fair?
I think I'd say yes, and I think that an important part, though, is it's making sure that we as the health plan are providing supports to help them succeed, though, as well. And that's where the data sharing, that's where whether it's the structural supports in the office, it could be an electronic medical record that the practice didn't have before, or it could be clinical decision support tools, or it could be even just connections with just other resources in the community, or that the plan, sometimes plans offer staffing, so it could be a nurse that can help with care management on site. So it's not just putting them at risk and then saying, all right, here's your money, go. It's all right, here's your money, we've got the population, and it's agreed upon goals that are set also for that. So it's not just the payer saying, okay, this is what we're giving you, figure it out. It's agreed upon goals and dollars, but then what supports can we provide to help you succeed? And I know CMS does that as well, and in many of their models, and I think that's a big component that is important in value-based care, especially as the farther along the continuum that you go with increasing the risk. While some of those practices or hospitals might be more sophisticated to begin with there, you still can't forget the making sure that we're supporting as well too.
Well, we're going to take some questions from the audience in just a few minutes, but before we get there, let's do a kind of a lightning round, because I want to hear from all of you what you think is ahead this year that will pertain to the topics that we've been discussing around value-based care. So what action steps or other events should people anticipate this year as we think about value? Now, we know we are in an election year, and sometimes not much happens in election years, and sometimes a lot happens in election years. So what do we think is ahead? And I'm going to start, Sarah, with you from the perspective of the Congress and particularly the House of Representatives.
Yeah, and thanks for that question. I think that that we're still trying to fund from last year. So thinking ahead, we're still thinking towards how to get through March so that we can ensure that the programs are funded. And part of that discussion, we've had discussions in the past on this, is related to, increased payments for Medicare providers, at least in the traditional Medicare side, lead into Medicare Advantage as well, for participating in value-based care models. And this has actually been, it's up for reauthorization. It's actually been difficult to try to get over the finish line, because I think that, as I had said earlier, there has been huge conversation about value-based care in the 2010s, and that all of the discussions on the Hill where we want, my organization is trying to improve value, and this is why. And I think that COVID kind of changed the discussion for a while, right? We were focusing on the immediate needs of the pandemic. There was obviously a huge monumental change in effects in the healthcare system and the way people received care. And I think it's an opportunity now to have to kind of think through and use kind of the shift in conversation from what it was in the 2010s to what it is now, to try to think through what does value mean and how do we want to move forward, and how to reorient the conversation back to value, and maybe in a different way, right? And thinking about all the different facets that come through value, thinking about access of care. There's so many different policies we can think about to improve access of care, and thinking about affordability. There's so many things that we can do to think about how to improve affordability and make sure people can get access and get the care they need when they need it. And then overarching all of that is certainly thinking about how to make sure that is all equitable. And there obviously every policy that comes through Congress relating to healthcare, you can fit into those buckets. And so I think once we, I think it's an opportunity now for a reorientation to try to think through what is value in the coming decade. Now that we've had this experience with over a decade with the Medicare Centers for Medicare and Medicaid Innovations for CMMI. From now we've had some time with the new physician payments. Now we've seen Medicare Advantage has grown to, from when almost doubled in the past decade, is now the majority of the Medicare program. Now that the private market is doing talking about value-based and risk arrangement models in a different way. Now that we have a much more vertically integrated system, I think a lot has changed in the past decade, and it's an opportunity to have to think through how we want to look at this and what we can do to move towards that, again, overarching view of right place, right time, and a place where that really right price, making sure things are affordable, accessible, and equitable.
Great, thank you. So I think a moment ago you were alluding to the question of the advanced alternative payment model bonuses, which are bonuses that go to clinicians participating in traditional Medicare, and it's a bonus that they get on top of the regular Medicare fees for being in these specified advanced alternative payment models. That bonus, of course, historically has been 5%, but it was cut last year to 3.5%. And what's on the table now for 2024 is cutting it again down to 1.75% and only extending it for a year. So stepping back, it looks like there isn't the wild enthusiasm necessarily for, at least for the bonus methodology, in terms of getting providers interested in value-based care. So I'm wondering, what does that signal about how seriously these issues are taken in Congress these days?
Yeah, it has been a big challenge. I want to say something that, my boss has always been a big promoter of value-based care. So it is frustrating and disappointing to think about how challenging. It was challenging to get the slash in half last year, or it wasn't quite in half, but the slash last year. And it's even more challenging to get thinking through how we're going to get the advanced CPMs reauthorized again for this year. They've already expired, as you know, and trying to think through making sure that we have incentives in place for providers to take the risk, to take the leap and make the investments into alternative payment models that are driving towards value. And I think that's why it's challenging and a little bit disappointing that we're having this kind of that it's so hard to get those over the finish line. But I think that it's also an opportunity to, again, reframe the discussion and think about what value is, and try to think about how what the next iteration of value, how we can make sure this is, again, that part is one component of Medicare, right? Making sure that individuals participate in advanced alternative payment models, which is a really important goal. But there's also thinking through, as you said before, how do we improve value across Medicare, across the healthcare sector, and how what we need to do to reach those goals. And so while it is frustrating, I will say, as we're knee deep into these negotiations currently, to think about, okay, this is one pillar that we've had in the value, in moving towards value. What are the next pillars we need to build to continue that march, and what is that, and what goal, how does the next iteration of value, what does that look like in terms of legislating?
Great. Well, I promise I'll come back to the rest of you for some quick predictions about what's ahead, but we also did promise some questions to the audience. So let me ask Allison to surface a few of the questions that have come in from the participants in the audience. Allison?
Great, we have one here for the group. Would appreciate it if Susan, Purva, and others can weigh in on what we may see for MACRA in the coming year.
Okay, so that goes back to MACRA, and I think it's fair to say that certainly from our perspective at APG, we don't anticipate a lot of big changes in MACRA this year. Would be a big lift to overhaul MACRA, even though we think it's needed. We see more efforts to kind of tee up a larger set of changes, possibly next year. I would just say that we think that MACRA, in many respects, has kind of outlived its usefulness. It was very important at the time. It got us out of a rut that the whole system was in around a prior formula for setting payment. but it was enacted in 2015, and it's 10 years, and a lot has happened in value-based care and other initiatives. So we're expecting lots of discussions around possible ways to reinvent MACRA and reboot it for the next decade. But I'll leave it there. Anybody else want to weigh in on that? Or Sarah, I guess we can turn that back to you as well.
Sure. I would say that, so I think about this. I was on a panel about how to move on to the next generation of MACRA when I just came back from my maternity leave for my daughter, who's almost 6. So I feel like this discussion is continuously ongoing. I think that there's a large discussion of how do we think about physician payments going forward, right? What worked in MACRA, what didn't work in MACRA? How do we harness what the opportunities of the things? That MACRA is a big goal, right? It wanted to get rid of the SGR, which is like giant cuts to physician payments that happened and caused that Congress had to deal with every 6 months, year, like there were so many different iterations. We needed to get off that roller coaster. And the idea was to move towards a value-based payment. And it had some goals about having, the idea was that most providers in the healthcare system would be in advanced alternative payment models right now. That goal has not been reached. But it was a good goal, and frankly, the discussion during MACRA, a lot of the providers and conversations were coming in. We're saying, we want to do more value. We want to, we want higher quality, and we want to be paid for containing our costs, and so we want to share in those savings and try to figure out how to move this ball forward. I think the discussion's a little bit different. Again, a change in COVID, in healthcare inflation, and just the staffing shortages. I think a lot of the focus lately has been on things like, how do we make sure people keep people afloat? And so again, it's a new opportunity to have those larger discussions. We've had lots of discussions on the Hill, bipartisanly, bicamerally. These types of discussions need to be bipartisan, need to be bicameral to make real change and real. And I think there's a commitment for everyone to have those kinds of discussions. And we've talked to lots of stakeholders, but I got to tell you, there's no consensus on the what's next. I think around the MACRA, there was lots of consensus. We need to get away from SGR and we want to move to value. There isn't a lot of consensus on what the next iteration should be. And those conversations need to continue because there needs to be, again, it's a new opportunity to think about how we should be going forward, and understanding the reality of the traditional Medicare landscape has changed from the conversations that we had when we undertook the MACRA discussions.
Right. Yes, and just to reiterate the final point, there still is a whole lot of healthcare systems sitting outside of value, and a lot of physicians sitting outside of value and firmly rooted in fee-for-service, and they will have to be part of the conversation about reinventing MACRA. So let's take another question, Allison. We want to try to then at least a couple more if we can, and then some additional predictions.
We have one more here. Value-based care has been focused in primary care. How do you see specialists being integrated or incentivized to be part of value-based care?
Great. Well, Purva, I know that you've been doing a lot of thinking on that at the Innovation Center, and some of the models really are tailored more at the specialist component as much certainly as primary care. But how are you thinking about that at this point?
I'm happy to talk about that for a minute. We agree. We think it's really important for all of our providers to be engaged in value-based care. A lot of our models have been focused on primary care, and I think Anshu said it earlier that it's really important that we think about primary care as the foundation of our healthcare system, right? High-performing health systems have strong primary care, and so that's always been a robust part of the Innovation Center's portfolio. But we know that that's not the only place people receive care. I mean, I had that statistic that I had shared earlier about the number of, chronic conditions that beneficiaries have, the number of physicians that we're seeing. And so we know that there needs to be better connections and integration between primary and specialty care. So over the last few years, we've actually developed, and I won't go into all the details here, but a 4-pronged specialty care strategy. That how do we take a really holistic, comprehensive view across the health system, really thinking about what's a patient's journey like through the health system across primary and specialty care, and then how are we testing innovations, whether it's new models, ways of providing data to foster that kind of integration, coordination, and collaboration. So we are looking at ways of providing data to accountable care organizations, providing new kinds of data to primary care physicians so they can identify high value specialty providers in their area that they can refer their patients to. We also had a request for information that we released last summer. We were thinking about the next generation episodic based payment model for the Innovation Center and what that looks like. And we got a lot of robust responses and engagement on that. It's really informing our work there moving forward. And then we also are looking at some ways of bringing specialists more directly into value-based payment programs. And then the last is really thinking about our overall broader strategy around accountable care and really getting all of our beneficiaries into what we call accountable care relationships, so they're receiving that team-based care with providers that are responsible and for the cost and quality of their care. We know there's a lot of opportunities to think about how specialists are also integrating into and interacting with our accountable care organization. So a multi-pronged view, knowing that not every clinician or physician sits in the same place in the system. Patients are moving through the system in different ways. And so we really need at the Innovation Center to be innovating both from model and data perspectives as well.
Great. Thanks so much, Purva. Well, in just a few minutes we have left, I want to go back to predictions, or at least some analysis of what we think lies ahead for this year. And if the others of you who I'll call on now will take it just about a minute each, that would help us to get that subject on the board, but also end on time. So David, let me ask you, what are you anticipating for the balance of this year in the realm of value-based care?
Well, it's a little awkward with Sarah and Purva on the call as well, but absolutely the advanced APM incentives that you talked about have been talked about are absolutely on the table, and something to watch for. If this is a call for press and media, a lot more coverage and attention goes to physician payments, but that APM incentive is absolutely something to keep an eye out for. But as Sarah talked about, and you did too, Susan, a lot of efforts to try to think about how to reform incentives to encourage participation in some of these value models. It's currently all the incentives are geared toward fee for service. So how can we sort of flip that and make it more advantageous, more carrots for APM participation, watching for all the ways that Purva had mentioned on ways to bring in more providers into some of these models. We in NACOS have come up with ways to bring in rural providers, specialists, long-term care providers, all these sort of non-traditional physician offices and hospitals. One thing to also think about, to ask more questions on is how do we pay providers within MA and commercial plans? A lot of the attention goes to what is paid to the plans, but how do those plans then turn around and contract and pay their providers? That's a way to recognize and reward value. So let's keep an eye out and try to ask questions on that. So I'll stop there.
Great, thanks so much. And Anshu, from the standpoint of commercial plans, what's ahead for this year?
Yeah, I think a few things jump out that may be unique from what David just mentioned. I think a lot of commercial plans, I know specifically like Blue Cross Blue Shield companies, we're really looking at the health equity side of things and how to incorporate health equity more effectively into value-based care models, so that it's not just a couple of measures that are out there that are being measured, but it's actually really embedded in the models. We're also looking at, as we all know, that there's a shortage of behavioral health and mental health providers and primary care through collaborative care models. A lot of primary care physicians have taken on some of those responsibilities, and there are models designed around those to integrate behavioral health into primary care, and then pay differently for the additional care and then that type of care. And so how can we better support providers there to address some of the behavioral health needs in this country, but doing it through the construct of a value-based care model. And then I think also just the role of telehealth, virtual care, just technologies. As care delivery has changed. The pandemic changed a lot of it, and just the way that people access the healthcare system. Are there different types of value-based care models that are out there that we need to start taking a look at that could be effective in delivering high quality care, effective care, but at lower costs? And any momentum from the pandemic for some of these alternative delivery models like telehealth, is there something there in the value-based care side for those models too?
Great. Well, speaking from the standpoint of a faux alien here who has listened to this conversation, certainly were I an alien, I would come away with a much better understanding of the issues than when I landed here on Earth. But I do want to thank both our cast of Earthlings who explained all of this today so well, and all of you in the audience. We hope you benefited from this really holistic, wide-ranging conversation about the value of value-based care. So with that, let me turn it back over to Allison to close us out.
Great. Thank you so much, Susan, Purva, David, Sarah, and Anshu for joining us for this important conversation. And thanks to all of you in the audience who took the time to be here with us today. Before we go, we want to hear from you. We appreciate you taking a few minutes to complete a brief evaluation survey, and you can find that link in the chat, and you will also be receiving an email later today with that link. Finally, I want to make sure that all of you in our community are aware of our very exciting news, which is today Claire Sheehan has joined us as the Alliance's new president and CEO. We are so thrilled to welcome Claire in this new role, and you'll be seeing more of her in the coming months, and we encourage you to sign up for our email list to receive the latest updates and stay connected to what we do next. As a reminder, a recording of this webinar and additional materials will be available on the Alliance website. And this concludes today's event. We look forward to seeing you at future Alliance gatherings. Thank you.